Okay, so part 2, cultural competency. This is a pretty good companion presentation with the health literacy part, another one of the soft sciences that plays a critical part in good patient care and safe patient care. So I hope that there's a lot of information in here that you find interesting and that you're able to use in your own practices. So just again, this presentation is worth 1 AMA PRA Category 1 credit. And once again, I am not an attorney and will not be providing any legal advice. And we also have no financial relationships with regard to this presentation. So our learning objectives today are to review the connection between cultural competency and your liability risk exposure. And we want to support your ability to respond to challenges that may emerge when you're working with culturally, linguistically, and literacy diverse populations. And to apply some strategies to reduce those communication barriers with your limited English-speaking patients. And make your practice comfortable for the LGBTQI population as well. We're going to be discussing different cultures and their beliefs. NorCal does not intend to promote stereotyping individuals based on their cultural backgrounds. And patients must be considered first as individuals and not as representatives of their culture or their race. Let me know if I'm not pressing hard enough on this. I think I didn't have the slides go. Okay, I'll try to look at the slides too. Our first pretest question is, why is cultural competency important? First, the U.S. has become more diverse. The physician-to-patient communication is linked to patient satisfaction and compliance with care. And there's an increased focus on improved quality and eliminating racial, ethnic healthcare disparities. You're so smart. Yeah, all of the above. When selecting an interpreter for a patient, you should determine if the interpreter has demonstrated proficiency in both English and the other language, a relationship with the patient or the family, orientation and training that includes skills and ethics of interpreting, or all of the above. All of the above, right. What are 3 special considerations for the LGBTQI youth? Rejection, bullying, substance abuse, economic security, all of the above, 1 and 3, or 1, 2, and 3. Tried to make this one a little more challenging. What do you think? 1, 2, 3. Yeah, you're right. Number 7. Well, culture is often described as the combination of a body of knowledge, a body of belief, and a body of behavior. It involves a number of elements, including personal identification, language, thoughts, communications, actions, customs, and beliefs, as well as values and institutions that are often specific to ethnic, racial, religious, geographic, or social groups. For the provider of health information or health care, these elements do influence beliefs and belief systems surrounding the health and the healing, wellness, illness, disease, and delivery of health services. The concept of cultural respect has a positive effect on patient care delivery by enabling providers to deliver services that are respectful of and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse patients. Cultural competence has been defined by the Office of Minority Health as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. So why is cultural respect important? It's important because it is absolutely critical to reducing healthcare disparities and improving access to high-quality health care. Healthcare that's respectful and responsive to the needs of a diverse group of patients. When it's developed and implemented as a framework, cultural respect enables systems, agencies, and healthcare professionals to function effectively to understand the needs of various groups that are accessing health information and health care. Cultural competence refers to a clinician's ability to respect and respond to the specific needs and preferences of ethnically, culturally, racially, and/or linguistically diverse patients and coworkers. It goes beyond providing language access services to a patient with limited English proficiency. Here are a few examples of culturally related beliefs and practices that may pose a challenge to the clinical encounter. The first one is that all conditions can be treated as if they were infections, such as with a course of antibiotics. This belief leads to difficulty understanding chronic disease management, such as diabetes or hypertension. Number two is that illness is caused by being out of balance with the world, or in some cases, spirits possessing the body of the patient. And number three, healthcare decision-making must be accomplished by family agreement or by a religious or spiritual leader, such as a priest, a shaman, a clan leader. And four, personal modesty prohibits being treated by a member of the opposite sex. And five, if one talks about illness or death, it's most likely to happen. And six, a scar or a loss of a body part prohibits the person from passing into the afterlife. Understanding the beliefs and practices of culturally diverse patients is an important aspect of developing a culturally competent healthcare practice. So let's look at the goal of cultural competence. Communication is the biggest barrier to meeting the goal of cultural competence. Effective physician and clinician-patient communication is a key aspect of patient safety, as we all know, and patient satisfaction as well. Unfortunately, cultural, ethnic, linguistic, and/or literacy differences between a clinician and patient can significantly impact the communication in the clinical encounter. As the numbers of patients from diverse racial, ethnic, and cultural backgrounds steadily increase in the U.S., the prevention of cross-cultural miscommunication in the healthcare setting increases in importance. Misunderstandings that are stemming from cultural differences or a patient's ability to understand medical information can affect core aspects of providing health care, such as informed consent, pain relief, and medication adherence. Consequently, achieving an appropriate level of cultural competency and compensating for patient deficits in patient health literacy have become necessities in today's healthcare environment. Few medical liability claims are based solely on cultural competency or health literacy. But when these issues do affect communication, they can contribute significantly in a patient's decision to file a lawsuit. So why is it important? Cultural competence has emerged as an important issue for three practical reasons. First, as the United States becomes more diverse, physicians and other clinicians will increasingly see patients with a broad range of perspectives regarding health, often influenced by their social or cultural backgrounds. For instance, patients may present their symptoms quite differently from the way they're presented in medical textbooks, and they may have limited English proficiency, different thresholds for seeking care, or expectations about their care, or unfamiliar beliefs that influence whether or not they adhere to a physician or other clinician's recommendations. Second, research has shown that physician-to-patient communication is linked to patient satisfaction, adherence to medical instructions, and health outcomes. So poor health outcomes may result when sociocultural differences between patients and physicians and other clinicians are not reconciled in the clinical encounter. Ultimately, these barriers don't apply only to minority groups, but may simply be more pronounced in these cases. And finally, 2 landmark Institute of Medicine reports, Crossing the Quality Chasm and Unequal Treatment, highlight the importance of patient-centered care and cultural competence in improving quality and eliminating racial and ethnic healthcare disparities. Providing culturally competent care is more than a medical liability risk issue. It's a basic aspect of patient safety. So let's look at some statistics on cultural competency and disease risk. Cardiovascular disease is the leading cause of death in the U.S. Non-Hispanic Black adults are at least 50% more likely to die of heart disease or stroke prematurely, that is, before the age of 75, than their non-Hispanic white counterparts. Although death rates from cardiac heart disease and stroke are declining overall, disparities still remain in the rate of death from these events between racial and ethnic groups. The premature death rate from cardiac heart disease and stroke continues to be higher among Black adults than their white counterparts. The prevalence of adult diabetes is higher among the Hispanic population, the non-Hispanic Black population, and those of other or mixed races than among the Asian and non-Hispanic white populations. And the infant mortality rate for non-Hispanic Black population is more than double the rate for the non-Hispanic white population. And men are far more likely to commit suicide than women, regardless of age or race or ethnicity, with overall rates nearly 4 times those of women. For both men and women, suicide rates are highest among the American Indian, Alaska Natives, and non-Hispanic white populations. Racial and ethnic minorities may perceive more instances of discrimination in the medical care system. They may tend to be less satisfied with their health care, and they may have higher levels of distress in their physicians and other clinicians providing their care. They may also be less likely to comply with treatment if they are not helped to understand or if they have conflicting health beliefs. Distress, dissatisfaction, and poor outcomes play a significant role in a patient's decision to file a lawsuit against their physician or clinician. Consequently, in order to manage liability risk, physicians and other clinicians should find ways to facilitate clear communications with patients and should allow patient beliefs and practices to be part of the healthcare discussion and their decision-making process. The first step in assessing your practice for cultural competency starts with an awareness of the impact of sociocultural factors on the clinical encounter, the education about one's own patient's cultures, and the knowledge about one's own cultural biases. In some instances, the cultural barrier originates with the patient. For example, you may have a female patient whose religion prohibits the provision of health care to females by males. So she'll most likely refuse treatment if the physician or other clinician is a male. In other cases, the barrier originates with the physician. whether conscious of doing so or not. For example, one study showed that physicians and other clinicians communicate abnormal test results less adequately to minority patients than to white patients. Another study found that oncologists gave more medical information to younger, well-educated and white patients than to older, less educated or non-white patients. So let's take a look at your own practice and whether it's patient-centered. The way in which patients interact with healthcare practitioners can be influenced by culture. To effectively communicate, regardless of language or cultural differences, physicians and other clinicians should specifically ask patients about their needs and their preferences. Providing patient-centered care means viewing patients as individuals with unique experiences, not simply members of one ethnic group or another. While it's important to learn about culture-specific healthcare beliefs that may be common in your patient populations, it's equally important to understand the risks of stereotyping based on cultural assumptions. So what kind of impressions do patients have of your practice? Is the patient care patient-centered? Is it a welcoming, calm environment? Is there an attitude of helpfulness from all your staff, including patient-friendly appointment scheduling, patient-friendly check-in procedures, and easy-to-follow instructions for referrals and tests? Are there patient-centered handouts and educational materials? Are they in the patient's native language? There are resources available for patients who speak languages other than English through the National Network of Libraries of Medicine, as well as the National Patient Safety Foundation, which I mentioned in the last presentation, and the National Institutes of Health, and other sites. And I've listed all of these on the resource slide at the end. There's quite a few of them, and I encourage you to take a look at those resources and see if they would be of some value for your practice. Do you have follow-up calls with your patients? And is there any type of case management for patients who need a little extra help? Okay, let's spend a little bit of time discussing the limited English proficient patient, since that's probably the most common situation that's occurring in your practices. Oops. According to the federal government, individuals who do not speak English as their primary language and who have a limited ability to read, write, speak, or understand English can be limited English proficient, or LEP. There are multiple liability exposures that arise when caring for LEP patients. These may include situations related to patient comprehension of the medical plan, the treatment plan, the discharge instructions, complications and follow-up, inaccurate and incomplete medical histories, ineffective or improper use of medications or serious medication errors, improper preparation for tests and procedures, and poor or inadequate informed consent. Let's look at a case study where an LEP patient's informed consent process was not handled properly. We have an allegation of failure to provide appropriate interpretation during the informed consent process, which resulted in a patient having her leg amputated without her consent. The patient was a 62-year-old Laotian immigrant. She was part of a large Hmong community who lived in the vicinity of the hospital. She spoke Hmong but was unable to read or write the language. She neither spoke nor read any English. She had a history of diabetes, hypertension, and kidney problems. She presented to the emergency department by ambulance for foot pain due to a sore on her foot that was not healing. She was not provided with an interpreter. After her admission, she was presented with various forms to sign. And because she could not read the forms, which were in English, and could not understand the English-speaking hospital employee who was presenting them, she refused to sign them. The next morning, x-rays were taken of the patient's leg. She was diagnosed with a life-threatening infection, and this necessitated debridement and the possible amputation of her foot or lower leg. Shortly before her operation, while she was in the preoperative room, the patient was approached by a Hmong-speaking woman and the surgeon, the surgeon himself. The patient had seen this woman cleaning some rooms around the area at the time. So the surgeon, through the housekeeper interpreter, told the patient her foot wound needed debridement and that he might have to amputate both her foot and her leg, depending on how advanced the infection was. The patient, however, thought the doctor was seeking permission only to clean her foot. She was presented with a consent form. She initially refused to sign the consent form, but after repeated assurances from the interpreter that it was just for permission to clean her foot, she went ahead and signed them. The interpreter did not translate the consent form into Hmong for the patient. The consent form contained a place for the interpreter's signature, indicating that the consent form had been orally translated for the patient, but that part of the consent form was left blank. The patient was put under general anesthesia. The surgeon, who thought that the patient had consented to a possible amputation, determined that her lower leg needed to be amputated, and he did so. The patient woke up and discovered that her lower leg had been amputated, and she began uncontrollably crying. Because none of the providers at her bedside could understand what was upsetting her, an interpreter was called in from the hospital's interpreter service. This is another official hospital interpreter this time. Through the interpreter, the patient was able to express her anger and grief over having lost her leg. The surgeon, seeing the patient's reaction to the amputation, realized that something had gone terribly wrong. But at that point, he felt there was really nothing he could do but move ahead with fitting the patient with the prosthesis. Following the amputation, the hospital continued to treat the patient without an official interpreter, except for some isolated incidents. On numerous occasions, the hospital required that the patient's son or daughter act as an interpreter. The patient and her husband filed a lawsuit against the hospital and the surgeon based on the following claims. The first was battery. The patient's leg was amputated without her consent. The second was violation of state and federal civil rights laws. The physician and the hospital staff discriminated against them by failing to provide interpreters. The third was negligence. The hospital negligently failed to supervise, train, hire, and retain managers, staff agents, and contractors to ensure that interpretation and translations were readily available at the hospital. And 4, negligent and intentional infliction of emotional distress. And 5, violations of state and federal privacy regulations, and that while they were translating, the family members gained access to proprietary medical information. After multiple depositions, a government investigation, mediation, and various court hearings, the hospital and the surgeon were able to negotiate a settlement with the patient. So let's discuss what happened with this case. Although the hospital contracted for interpretation services, in this case, a bilingual staff member, the housekeeper, had been asked to interpret. And whether this person was competent to interpret was never established. Her identity was not disclosed in the patient's medical chart because the consent form, again, remember it was left blank where it should have had her name in there. And during the litigation process, it became clear that the surgeon and other clinicians who had treated this patient had violated several of the hospital's own policies on providing competent interpreters to patients with limited English proficiency. And these policies included, one, that the staff did not have the patient sign the consent forms in the patient's primary language. And two, the staff member who translated, again, did not sign the required confirmation on the form. And three, the physician and the staff subsequently requested that family members be used as interpreters, although in each case there was no emergency and the patient had not requested that a family member be used as an interpreter. And had the hospital staff followed their own policies and had the surgeon made a greater effort to confirm the accuracy of the translation during the informed consent process, this claim might never have been filed. Title VI of the U.S. Civil Rights Law of 1964 has been interpreted to prohibit hospitals, physicians, and other healthcare clinicians receiving federal financial assistance from discriminating against patients who don't speak English. The U.S. Department of Health and Human Services published a list of the types of federal financial assistance to which Title VI applies, which includes services that are reimbursed under Medicare Part A. So how can a physician best comply with this obligation? And believe me, I know better than anyone what a hot topic interpreters are for physicians. So I'm going to try to give you some assistance here. First of all, you might want to consider establishing a formal compliance plan that consists of identification of LEP persons. You want to conduct a thorough assessment of the language needs of the population that you serve. And develop a policy on language assistant measures. What are you going to do that will ensure meaningful communication for this patient population? And training your staff. Take steps to ensure that your staff understands the policy and that they're capable of carrying it out. And providing notice to your LEP patients that language assistance is available to them. And then, of course, you want to monitor and update your LEP plan by conducting regular oversight of it to ensure that it gets updated when it needs to be, based on your population needs. Even though the costs of interpreters may not be considered reasonable, when the costs exceed the benefits of providing the language services, such as providing an on-site interpreter, physicians should remember that costs may be reduced by technological advances, by sharing language assistance materials, by use of bilingual staff, and by pooling some resources with other physicians in your area. Standardizing documents, or the use of qualified community volunteers. This is a guide that I found, and this is just a sample piece of it. The complete guide is on the AMA website, and it's called the Office Guide to Communicating with Limited English Proficient Patients. And it's a very nice tool to have in your office, and again, it's a free download. And some of the things that I think are really nice is it tells you the types of interpreters on the left side and what their ability would be for interpreting, their professionalism, the comfort to the patient, the interpreting quality, and the circumstances where it's appropriate. And I think that the far left and the far right are the most important pieces. You know, if it's an emergency situation, a patient is, life or death, then maybe using a family member would be appropriate. But when it's not an emergency and you're dealing with a chronic health problem such as diabetes or hypertension, it's best to have a qualified interpreter so that the patient fully understands what the care plan is going to be and understands their medications. So how can you determine whether someone is competent to interpret for your patients? And competency doesn't necessarily mean formal certification as an interpreter, although that can be very helpful. On the other hand, competency requires more than self-identification as bilingual as well. The competency requirement considers a demonstrated proficiency in both the English and the other language that you're trying to interpret, the orientation and training that includes the skills and the ethics of interpreting, such as the issues of confidentiality, and a fundamental knowledge in both language of any specialized terms or concepts that are peculiar to the patient or to the clinic. Also, sensitivity to the LEP person's culture as well, that certainly ties into it. And a demonstrated ability to convey information in both the languages accurately, and an understanding of confidentiality and impartiality rules and adherence to the role of the interpreter versus a counselor or a legal advisor. Many physicians ask us, my LEP patients typically bring a family member to translate. Is that sufficient? Well, not necessarily. Some LEP patients may feel more comfortable when a trusted family member or friend acts as an interpreter. And if you determine that their interpretation qualities are adequate for the visit, then by all means, you can use them. But other folks may not be appropriate interpreters. When an LEP person attempts to access the services of a physician or another clinician, the staff should make the LEP person aware that he or she has the option of having the physician or clinician provide an interpreter for him or her without charge, or of using his or her own interpreter. And physicians and other clinicians should also consider whether a family member or a friend should serve as an interpreter, as I mentioned, such as whether the situation is an emergency and whether there are concerns over competency, confidentiality, privacy, or even a conflict of interest. Additionally, physicians and other clinicians should remember that family members, and especially children, may not be appropriate interpreters because they may not provide quality and accurate interpretations. And privacy and conflict of interest issues may also arise in that situation. There may be some new technologies on the horizon to assist you with interpreting services in your practice. Technology is just getting better and better as the years go by. So video conferencing and voice-activated software were mentioned in that AMA office guide that I told you about. So keep a lookout on the horizon for those types of services for you. If you must work with an ad hoc interpreter, there are some tips you can follow to make sure that your information is being exchanged accurately. First of all, you want to introduce yourself to the patient, then the interpreter. And gauge the interpreter's level of English skills and professional training. Remind the interpreter to interpret everything accurately and completely, and direct the interpreter to avoid any paraphrasing or answering for the patient, and to let you know if you should repeat yourself or slow down or explain something more clearly. And if needed, introduce the interpreter to the patient and explain the interpreter's role for the visit. And in general, position the interpreter next to and a bit behind the patient. And if you're concerned that the interpreter has not interpreted everything, ask him or her to do so. And if the interpreter and the patient get into a conversation that is not interpreted for you, interrupt and ask the interpreter to let you know what is being said and what the concerns are. You want to interact frequently with the patient. Use the teach back method by requesting, please tell me everything I just told you, and then have the interpreter interpret that back to you. And speak simply and pause between sentences. Remember to speak to the patient and not the interpreter. We're going to switch gears now and discuss a population of patients with some unique psychosocial and healthcare needs. The rainbow flag is a symbol of the diversity within the LGBTQI community. Often people of this community get lumped into one group when actually the community is comprised of many cultures, generations, and sexual identities. Although defining these terms is necessary in order to discuss LGBTQI populations, keep in mind that these definitions and others are imprecise and they're often controversial because of the fluidity of human sexuality within and between cultures across time. A lesbian is a woman who's emotionally, romantically, and/or sexually attracted to other women. Gay is a man who's attracted emotionally, romantically, and/or sexually to other men. Bisexual is a person who is attracted to two genders, but not necessarily simultaneously or equally. And transgendered or transsexual individuals are those whose gender identity, whether they're male or female, does not match their biological sex. And transsexual individuals will seek medical intervention to more closely align their physical appearance with their gender identity. Queer is just an umbrella term for sexual minorities that are not heterosexual, heteronormative, or gender binary. And this term may be controversial, but it is sometimes used. Questioning is someone that is questioning their sexual orientation. They're unsure which gender they are attracted to. And intersex are people who are born with physical markers, sex chromosomes, external genitalia, or internal reproductive systems that are not considered standard for either male or female. Many health concerns of the LGBTQI community are shared amongst all its members. For example, discrimination, harassment, and physical violence can cause anxiety and depression in LGBTQI individuals, leading to low self-esteem, feelings of powerlessness, substance abuse, and suicide. And while not conclusive, recent data suggests that LGBTQI individuals may use tobacco, alcohol, and other drugs at higher rates than does the rest of the population. Furthermore, the perception of LGBTQI discrimination in the healthcare community has led to a reduction in access to healthcare services. Healthcare access is also threatened because existing legislation often does not allow LGBTQI partners to share medical insurance and restricts medical decision-making rights. Domestic violence between LGBTQI partners may go unnoticed by physicians and other clinicians who assume it's only a heterosexual issue. The topic of LGBTQI healthcare considerations is a presentation in and of itself. So I'm going to focus on two age groups with unique issues and needs: the young LGBTQI patients and the senior LGBTQI patients. So we'll discuss the young LGBTQI patients first. In addition to the common challenges of being a teenager, LGBTQI teens and youth face a number of unique challenges. For example, they may face a lack of support or outright rejection from people who are close to them, such as family members, friends, and classmates, or from people in authority, such as clergy, people, teachers, and coaches. Many LGBTQI youth are subject to bullying, harassment, threats, and violence. And according to the Institute of Medicine report, The Health of Lesbian, Gay, Bisexual, and Transgender People, Building a Foundation for Better Understanding, LGBTQI youth as a group may experience higher rates of smoking, alcohol use, substance abuse, HIV and other STD infections, anxiety, depression, suicidal ideation and attempts, and eating disorders. Physicians and other clinicians should be aware of these risks and be prepared with education, referrals, and resources for them. The physician or clinician may be the only adult confidant that this patient has. So the degree of safety, comfort, openness, and respect that these patients feel often has an impact on their future access to health care, their risk reduction, and help-seeking behaviors. Let's look at the senior population now. The LGBTQI elders have the same concerns about aging as the rest of the population does, in addition to some important and unique challenges and concerns. They also experience discrimination, fear of discrimination, stigma, and victimization within the healthcare system. According to the IOM report, LGBTQI elders are less likely to have children than heterosexual elders, and they're less likely to receive care from adult children. They may have higher rates of isolation due to a lack of family or social support. And because Social Security and most private pension plans do not provide spousal or survival benefits to unmarried partners, the disability or death of one partner may threaten the economic security of the surviving partner. LGBTQI seniors in residential facilities are particularly vulnerable to hostile or unwelcoming environments and may experience pressure to go back into the closet or risk being denied visitation with loved ones or rooming options. Fortunately, many initiatives are underway to address issues for LGBTQI seniors. Notably, in October of 2010, SAGE, which is Services and Advocacy for LGBT Elders, in partnership with 10 leading organizations, launched the National Resource Center on LGBT Aging. And this resource center serves as a comprehensive clearinghouse of information for providers of the aging population, LGBT organizations, and the LGBT or older adults. So what can you do in your own practice to serve this unique community? Create a welcoming environment that is inclusive of LGBT patients. Many studies have demonstrated that LGBT patients and their families really survey their surroundings to determine if the environment is one in which they feel welcome and accepted. Providing a welcoming environment can set the tone for the entire healthcare encounter. Your waiting rooms and other common areas should reflect and be inclusive of LGBT families and patients. Brochures and other available reading material should include topics relevant to LGBT patients, as well as general brochures. LGBT-relevant magazines, posters, and information about local resources should also be available to them. And decor and images depicting couples and families should include same-sex partners, same-sex parents, and LGBT families. LGBT-friendly symbols such as the rainbow flag, the pink triangle, or safe zone sign can be displayed in waiting areas on placards and on forms or on staff badges and can immediately signal a culture of acceptance within your practice. And foster an environment that supports and nurtures all patients and families. A welcoming environment is one in which all patients and families feel comfortable expressing love and support for one another. The healthcare encounter can be a time of considerable stress and fear and anxiety for the patient. So be aware that visible discomfort on the part of your staff or other patients in the presence of LGBT families can be extremely stressful for them. You want to determine mechanisms for handling patient-to-patient discrimination while preserving the dignity of all that are involved. And be aware of misconceptions, bias, stereotypes, and other communication barriers that may occur. While an understanding of a person's sexual orientation or gender identity is important, this information alone does not say anything about a patient's family relationships, their religion, their class, their socioeconomic status, their beliefs, their race, ethnicity, their ability or disability, behaviors, or other factors that may impact their health and well-being. You want to avoid assumptions about any of these based on stereotypes, misconceptions, or bias. And avoid assumptions about sexual orientation and gender identity. Remember that any patient can be LGBT, regardless of appearance, the behavior, their age, their self-identification, socioeconomic status, religion, race, or ethnicity. And refrain from making assumptions about a person's sexual orientation or gender identity based on appearance. Don't rely on external appearances to determine the sexual orientation or gender identity of a patient. Information about a patient's sexual orientation or gender identity should come only from the patient. Incorrect assumptions about a patient's sexual orientation or gender identity can interfere with the establishment of trust and rapport and can lead to inappropriate care. And be aware that a patient wearing a wedding ring may be partnered with another man or woman, and someone whose appearance is typically masculine or feminine may have transitioned to another gender. It's not always possible to determine by appearance if a patient is transgender or is struggling with gender identity. If you're unsure of a person's gender identity or how they wish to be addressed, ask gender-neutral questions for clarifications, such as how would you like to be addressed, or what name would you like to be called? And recognize that self-identification and behaviors do not always align. How an individual identifies and what behaviors he or she engages in can be fluid and change over time. For example, a man may identify as heterosexual but engage in sex with other men, or a woman may identify as a lesbian but has had relationships with men in the past. In addition, the ways in which people use identity labels often vary among cultural, racial, ethnic, socioeconomic, and age groups. So refrain from making assumptions about patients' health needs based on their identification alone. And facilitate disclosure of sexual orientation and gender identity, but be aware that this disclosure or coming out is an individual process. Physicians and other clinicians should make it as easy as possible for patients who choose to self-identify, but need to remember that this decision is up to the individual patient. And honor and respect the individual's decision and pacing in providing information. Be aware that patients may or may not choose to self-identify, and allow them to provide that information at their own pace. And you want to use neutral and inclusive language in interviews and when talking with all of your patients. Interactions with patients that are sensitive and non-judgmental will pave the way for more effective patient-physician communication and can make patients more comfortable with disclosing even more information to you. How a question is phrased can communicate acceptance and consideration for a range of partner or family relationships. Be aware of language or questions that assume heterosexuality, such as, "Are you married?" or references to husbands or wives. And when asking about family relations, ask who are the important people in your life, or who is family to you? And listen to and reflect the patient's choice of language when describing their own sexual orientation and how the patient refers to their relationship partner. Notice the language that LGBT patients use to describe sexual orientation, gender identity, partners, and relationships, and reflect the choice of terminology when it's appropriate. And never assign a label to a person's sexual orientation by inference. And all forms that you have within your practice should contain inclusive, gender-neutral language that allows for self-identification. The admitting, registration, and all other patient forms should provide options that are inclusive of LGBT patients and families, and should allow LGBT patients to self-identify if they choose to do so. For example, provide options such as partnered under relationship status. And for parents, use terminology such as parent/guardian, which is inclusive of same-sex parents who may or may not be biologically related to the child. And provide information and guidance for the specific health concerns facing lesbian and bisexual women, gay and bisexual men, and transgender people. Although LGBT individuals may share some of the negative health consequences associated with the experience of being stigmatized and/or the reluctance to seek medical care, each subpopulation has unique health concerns. Physicians and other healthcare clinicians need to be prepared with information, guidance, screenings, and referrals for the conditions that affect the group as a whole and those that disproportionately affect each subpopulation. Become familiar with online and local resources available for LGBT people. I know that when preparing this presentation, I found a lot of information when I did my research. So there is a lot of medical information out there regarding this patient population. And I did put a lot of the resources, even ones that I didn't necessarily cite in the presentation, I did put them on the resource list because I thought they were excellent resources. And seek information and stay up to date on LGBT health topics, and be prepared with those appropriate information and referrals. So for those of you who may be interested in assessing your own practice for cultural competency, I found a wonderful cultural competency self-assessment that can help physicians and other clinicians identify some of their own personal biases and determine which issues need correcting within their practice. And this awareness can help physicians improve quality of care and ultimately health outcomes. This is called the Cultural and Linguistic Competence Health Practitioner Assessment. And this is a validated measure of cultural and linguistic competence for healthcare practitioners. It enables practitioners seeking a health assessment a measure of cultural and linguistic competence to identify areas for improvement and allows for the development of learning plans to incorporate cultural and linguistic competence in their practices. So they do provide resources for you based on the scoring of the assessment. This tool measures cultural and linguistic competence in three psychometrically tested factors. Factor 1 is knowledge of culturally and linguistic diverse populations. Factor 2 is adapting practice for culturally and linguistically diverse patient populations. And Factor 3 is promoting the health of culturally and linguistically diverse communities. In addition, feedback on responses to items in the following two areas have been developed to enhance the assessment process. The first is linguistic competence, and the second is health and healthcare disparities. Okay. A report provides the scores and the level of performance on each factor and the two additional areas and a set of professional development and educational resources related to each one. And these are customized for your practice, and the report is available to download, print, and save. So we're on our post-test questions. Culture is often described as a body of knowledge, a body of beliefs, a body of behavior, 1 and 2, or all of the above? Very good. And how can you make your practice welcoming to the LGBTQI community? Provide brochures and other information that address the LGBTQI community. Customize forms and questionnaires to address the LGBTQI individuals. Include pictures of same-sex families along with other cultures and family structures in your practice, and all of the above. Right. And what cultural factors should be focused on when conducting a cultural assessment of your practice? Sociocultural factors, cultural biases, self-assessment, knowledge of patients' cultures, cultural barriers, 2 and 4, or all of the above? Very good. Excellent. And there are all the resources. I told you there were a lot of them, but there's a lot of information out there for you on cultural competency and on health literacy. So I hope you take the opportunity to look at them and avail yourselves to some of the free resources that are available for you.